Thanks, Brittany, and welcome everybody to the presentation. Let me get my thing set here. There we go. Sorry. There we go. Okay. As Brittany said, I'm with Urology of Indiana. Been with Urology of Indiana since 2005, but originally joined Associated Urologists in 1992. So this year I celebrate my 30th year in practice in the area. So I work out of our Carmel location, our Fishers. I don't work out of our Greenfield office anymore, but I also work out of the Nab Road office. And as Brittany shared, I'm an IU grad and then do my residency at Northwestern. Tonight we're going to go over a lot of general facets of prostate cancer. We're going to look at the anatomy, some basic statistics, go over diagnostics of prostate cancer, and then treatment options. I'm going to focus a little bit on radiation treatment specifically, and then talk about the SpaceOAR Hydrogel product, which Boston Scientific produces. First off, this is a side view of the male anatomy. I don't know if my pointer works here, but obviously the prostate sits here beneath the bladder. The urethra runs from the bladder through the prostate and then out through the urethra, sits in front of the rectum. This is a very important area that we're going to talk about later, this area right here between the rectum and the prostate. In terms of prostate cancer general statistics, about 1 man in 9 will be diagnosed with prostate cancer during his lifetime. It is the second leading cause of cancer death in American men behind lung cancer. Now, not every man obviously will become symptomatic or need treatment for their prostate cancer, but in general, this is how many men can get prostate cancer. In 2018, there were about 165,000 cases, about close to 30,000 deaths. The 5-year relative survival rate for localized disease was more than 99%. 5-year relative survival for all stages is combined 99%. And then the 10-year relative survival rate for all stages combined is 98%. So you can see that most men survive prostate cancer. Most men end up not necessarily dying of prostate cancer, but dying with prostate cancer if they live long enough. And obviously this is a disease that does exist in older men. Our job is to find it in men in whom it will be a significant player in their life, potentially even life-threatening, could potentially cause significant problems. And certainly if prostate cancer occurs in a younger man in his 40s, 50s, or early 60s, or even early 70s when they're very healthy, then it could have an impact on their life. And it's our job to work with the patient in a very patient-centered approach to figure out who's at risk for problems with their prostate cancer. We screen for prostate cancer with the PSA. There's a couple ways of looking at this. Are we trying to detect cancer? Are we screening for cancer? I like to think of it as prostate cancer detection. We do use the PSA blood test. There has been a lot of controversy about that in the last 10 to 12 years, but we strongly feel that the PSA is absolutely necessary to do in men over 50, and certainly in African-American men over the age of 40, and any man with a family history of prostate cancer. What's important is how we use the PSA in diagnosing prostate cancer. We don't necessarily biopsy every man that walks in the door with an elevated PSA. We have other ancillary tests that we can do, urine tests, blood tests, and some imaging procedures to see if the PSA is specifically risky for prostate cancer. So we don't necessarily biopsy everybody, and we know the imperfections of the PSA. We know it's a very specific blood test for prostate problems, but not necessarily specific for prostate cancer. But again, it's how we as urologists interpret the test and then how we use it. The digital rectal exam, this has come under some controversy recently. If you talk to a urologist, every urologist will tell a man he needs a digital rectal exam. For some reason in the primary care world, they're getting the word that they don't need to do rectal exams anymore. But we feel that digital rectal exams are absolutely necessary. And the big reason that's so is that in 20% of men diagnosed with prostate cancer, the PSA can be normal. And the only way we can find the cancer is by rectal exam. So that's 1 out of 5 patients. So it's very important to still have the rectal exam done. Sometimes patients present with symptoms, pain, urinary obstruction, bleeding, et cetera, and that can be when prostate cancer is found. And really the only way to confirm the existence and severity of prostate cancer is to do a biopsy. So we're getting closer to liquid biopsies or imaging specific tests for prostate cancer, but today as of June 5th, 2022, we still have to do a biopsy to confirm prostate cancer. Hang on. There we go. A couple ways to do biopsies. On the left, that's the transperineal approach, where we approach the prostate through the space between the anus and the scrotum. Both of these are done with ultrasound guidance. We will probably be moving towards transperineal biopsies more and more in the future, but right now, at Urology of Indiana anyway, we're still doing transrectal biopsies. One of the risks with transrectal biopsies is infection, but we've done a really good job in our group of preventing infections the way we give antibiotics. We have a fairly low, very acceptable infection rate, probably less than 1.5 or 2%. So, but this is the way biopsies are done. We have to grade and stage the cancer. The key pillars for non-metastatic disease are the Gleason score, the grade group, and then the T stage, the extent of cancer on clinical exam, and also the PSA test. This is how we determine the risk category for prostate cancer, whether it's a low risk, very low risk, intermediate risk, or high risk prostate cancer, based on the Gleason scoring and the stage. So the T stage is what we feel on the rectal exam, whether it's normal, which would be a T1 cancer. If we feel a small nodule, it could be that's a T2 cancer. If we feel something that's extensive outside the prostate, even, that's a T3. That's called a stage 3 cancer. The Gleason score is nothing but a way for us and the pathologist to look underneath the microscope, look at the cancer cells on the microscope and assign a grade to it based on how the cells are arranged and how the glands are configured. And that correlates very closely to how aggressive the cancer is potentially. Other factors are the PSA velocity. We can do genomic testing on the cancer. We look at the volume of tumor. And there's some other things that we can look at as well. But really the key pillars are the Gleason score, the stage, and the PSA. Then when we have the diagnosis, then we sit down and we have a very extensive conversation. Depending on the grade and stage of the cancer, we might do some additional imaging, bone scan and CAT scan, to determine the extent of cancer. And that plays into what we talk about with the patient. We look at the patient, we look at the cancer, and we assess all the risks and side effects of each of the treatment options. This slide only depicts 3 options, but these are the 3 major options available to us right now. Active surveillance, which means the cancer is usually lower grade and lower stage, usually a Gleason 3+3=6 cancer with low volume. Those cancers are extremely slow growing, well differentiated, we say, in a very low grade grouping, and those cancers move very slowly. And we use active surveillance to either delay treatment, or in some cases, we even avoid treatment. And what we're trying to do is avoid the side effects of surgery. And there's abundant literature about active surveillance and its efficacy. And there's been a number of papers that show that the outcomes, if a patient needs treatment after active surveillance, then his outcome is not affected by waiting or delaying that treatment. So we have a very active surveillance program at Urology of Indiana. If somebody needs or desires curative treatment, then the basic two curative options are radiation and surgery. And again, that's a long, involved conversation about assessing risks and benefits and going through the side effects, talking to the patient very carefully, and usually his family, his wife, again, using a very patient-centered approach to this decision, because it is a hard decision. Here are the different types of surgery, different types of radiation. And again, the risks and side effects usually center around bowel and urinary and sexual side effects. With urinary incontinence, erectile dysfunction, and bowel side effects with radiation therapy, which we'll go into in a minute. The box under active surveillance just reiterates what I just said. It says, because prostate cancer often grows very slowly, some men, especially those who might be older, have other serious health problems, might never need treatment for their prostate cancer. Instead, their doctors may recommend approaches such as active surveillance or watchful waiting. I've got a number of men who are younger, in their 50s, doing active surveillance, who have very low volume, very low risk disease. Radical prostatectomy is very active treatment at Urology of Indiana and in my practice as well. We're surgeons, and we know that surgery cures cancer, and in many cases, surgery is the best option, especially in younger men, and also perhaps patients with higher risk disease, where we realize that it'll be a combined approach to curing their cancer with surgery and radiation together. We can do prostatectomy several ways. We can do it with the originally described radical prostatectomy. That's an open surgery with an incision between the umbilicus and the pubic bone. Some are still using just a straight laparoscopic approach, but 90% of all surgeries in the United States now are done robotically assisted robotically assisted laparoscopic techniques. So, and we have a very active robotic program at Urology of Indiana. Radiation therapy involves a number of different options. There's in the past, we've used 3D conformal radiation therapy, and that morphed very quickly into intensity modulated radiation therapy, or IMRT. We also use image guidance, so it's technically called IMRT, IGRT. Recently, we've been trying to still maintain good treatment outcomes with radiation therapy, but reducing the number of treatments available. So stereotactic body radiotherapy, SBRT, is possible. The IGRT or IMRT is usually 25 treatments, five treatments a week, 5 weeks. SBRT can be done in 5 treatments. Brachytherapy are radioactive seeds that are placed. There are permanent seeds, so-called low dose rate, and then there's high dose rate, which are temporary seed treatments. Proton therapy is available, but that's kind of fallen by the wayside with the improvements in all these other radiation type treatment modalities. Quickly, well, as a radiation overview, prostate radiation therapy uses directed radioactive exposure, such as high energy X-rays, to kill cancer cells and surrounding tissues. Because the prostate and the rectum are very closely spaced, it's only separated by only a very small space, radiation often unintentionally causes damage to the rectum. So possible side effects of radiation therapy are bowel dysfunction. It could be diarrhea or blood in the stool, or possibly some mild leakage. The bladder sits close to the prostate, so there can be some urinary dysfunction with burning, with urination, even blood in the urine eventually, and remotely possible is incontinence. Getting back to the types of radiation therapy, external beam, there's the 3D conformal therapy, which closely morphed or evolved into the IMRT or GRT, and this is one type of treatment right here. Then some facilities are using SBRT for selected patients. Again, proton therapy used to be done down at Indiana University, but they shut down that treatment a number of years ago. Brachytherapy is internal beam, internal radiation, so-called. There's low dose rate implants, which are permanent. There's high dose rate implants, and then there's permanent implants, as we mentioned. So those treatments are available here in the Indianapolis area through Urology of Indiana as well. And your radiation oncologist will talk to you if you want to proceed with that type of treatment, if that's number one, if it's warranted, if it's possible, and if it's beneficial for you. There's not one particular treatment that suits all patients. Again, we do this in a very patient-directed, patient-centric way, and we try to pick the best treatment for the individual patient at all times. This is just a quick imaging procedure that our radiation oncologists use. And basically the colored section is the prostate, and this would be the treatment field. So you can see how closely the rectum, on the left-hand screen, how closely the rectum sits to the treatment field. On the right, you can see how closely the bladder and the urethra and the anal sphincter sits. You can just see how close everything is. You see the rectum here behind the prostate, and you can see how closely everything sits. So we're trying everything we can do to limit the scatter or collateral damage to the rectum and the urinary tract. So in terms of rectal toxicity in the real world, this is where the hydrogel spacer comes in a retrospective analysis entitled Early Tolerance and Tumor Control Outcomes with High Dose Ultra Hypofractionated Radiation Therapy for Prostate Cancer. Total of 551 patients were treated. They received the dose escalated SBRT. About half of those patients had a hydrogel spacer placed. And what we know is that that the use of the hydrogel rectal spacer was significantly associated with reduced late GI toxicity and lower odds of developing late GU toxicity. So the blue bars are where SpaceOAR was used, what was used in it, and you can see how much, how well things were, how the complications were limited. That's a good slide to indicate how successful the hydrogel spacer is. Here's a diagram of the SpaceOAR spacer that's going in. Rectal radiation is often unavoidable. There's a close proximity of the rectum to the prostate. The prostate can move between treatments. The prostate can move during treatments. And so if we can find some way to lift the prostate off the rectal wall, then that can limit and reduce the amount of damage potentially to the anterior surface of the rectum. Here's another view of that. The rectum is the organ at risk of receiving unintended radiation. Here's the prostate, here's the rectum. You can see the rate in the red is the radiation dose. Radiation oncologists typically try to get a band of treatment around the prostate, kind of a zone around the prostate so that they can eliminate any potential cancer cells that are outside the prostate. Rectal injury can significantly impact the quality of life. It can lead to bowel and urinary and sexual symptoms that can affect patient health and quality of life ongoing, even years later even. So the hydrogel implant temporarily positions the rectum away. It actually lifts the prostate off. It's designed to reduce rectal wall radiation exposure. It's inserted via a brief outpatient procedure, usually in our office. After about 6 months, the SpaceOAR material is naturally absorbed and removed through the urine. There are risks associated with this, and when your doctor does a SpaceOAR treatment, if it's indicated for you, he'll go through all the risks and benefits from this. Typically, it includes, but may not be limited to, inflammatory reactions, infection, bleeding, and pain or discomfort from the injection. The material is a synthetic, biocompatible, non-toxic material. It absorbs in about 6 months. It's made mostly of water and polyethylene glycol, or PEG. PEG is used in many medical products, including artificial tears, many prescription drugs, and medical implants. Again, it's a brief outpatient procedure under local anesthesia typically. If need be, we can use regional or even general anesthesia. It's been well studied. It's designed to provide a space between the rectum and the prostate, reducing the high dose radiation to the rectum. Control patients were 8 times more likely to have a decline in bowel and urinary and sexual quality of life when compared to SpaceOAR Hydrogel patients at 3 years. So more space, basically, with the clinical results, more space equals fewer rectal complications, fewer urinary complications, fewer sexual complications, and a better quality of life. Again, the control patients, meaning they did not get the SpaceOAR implant, they were 8 times more likely to have a decline in bowel, urinary, and sexual quality of life when compared to those who had an implant done. By the numbers, so this has been well studied. It's been reported, it's been studied and reported in more than 75 peer-reviewed publications. It's used in many of the leading cancer centers in the United States. Over 50,000 patients have been treated. It's well reimbursed by Medicare and a growing number of private insurance companies. And our office in particular will work closely with you to make sure this is covered. Having technical difficulties, so I can't really do the testimonial here. Suffice it to say, we've been doing these a long time, and we are very, very pleased with the outcomes. It's been very safe. We had very few complications, and I think our radiation oncologists will testify to the fact that it's made treatment better, easier, and much more safe, and hopefully more effective. So you can go to spaceoar.com for more resources, including physician locator, some other helpline and education materials. We do have resources through our office. If you're interested in having this, if the radiation oncologist wants you to have this, you will talk with us. You will talk with one of our navigators and our assistants to go through the whole procedure and walk you through how this is done and the process for getting the procedure done. So that is all I have right now. It's been a pleasure speaking with you, and I'm happy to answer any questions